next important aspect of our ECG reading. The most important application of ECG is in coronary artery disease. So now we have 2 lectures on coronary artery disease. First, the basis of coronary artery disease, and then we go into see what's happening in ST elevation MI, the course of ST elevation MI, how to diagnose each stage of ST elevation MI, and how to plan appropriate management in each one of these stages. So, shall we proceed? Yes. So, it is any country's aspiration to become world number 1. We are also aspiring to become world number 1. We are trying to become world number 1 in AIDS. Population, China is not allowing us. And of course, corruption. And we are trying to become economic superpower. We are keep on saying that we are going to become economic superpower. But we already became world number 1 in many things, test cricket and one-day cricket. But diabetes and coronary heart disease, we rapidly lost the other 2 places, rapidly lost the first place in test cricket and one-day cricket, but nobody can beat us in the first place in diabetes and coronary heart disease for years to come, unless we have some energetic implementation of policies and change of outlook of doctors. We are not going to be the number 1 in diabetes and coronary heart disease, especially coronary heart disease. Diabetes also China is competing. There is a controversy whether Chinese is the diabetes world number 1 and so on. But coronary heart disease, nobody is there to beat us. So still we are number 1. We are going to be number 1 in coronary heart disease. We have the at present you see the scenario in coronary heart disease in India. Now at present the 12% of urban population. It is 4 times more than states. It is 6 times more than Europeans and 20 times more than Japanese. The Japanese smoke more. Americans eat more. But we continue to suffer from coronary heart disease. Of course, tsunami is there to take care of Japanese, but they do not die of coronary heart disease. So the first episode of myocardial infarction occurs 10 years earlier when compared to the Western world. The average age of first myocardial infarction is 53 years in India. Once it is there, it progresses virulently. We see 45, 46 years or 48 years severe triple vessel disease, which is not seen in the Western population. It is seen in around 60s and 70s. The rural population is also competing with the urban population for the incident, not for betterment, for becoming more and more coronary heart disease. The main problem here is the young patients having coronary heart disease. 50% of myocardial infarction occur at below the age of 50 years, and 60% of world's cardiac patients are Indians in 2010 itself. So I think and suggest majority of you take cardiology, because you have huge patient population to take care of. So we will not have any decrease in practice if you take cardiology, because many of the patients will be Indians. Death due to myocardial infarction is 2 to 3 times greater in India, because in India identical diseases don't get identical treatment. Different types of treatment are there depending upon where the patient is living, what is economic status and so on. So for example, in Western world, a fellow with acute myocardial infarction, wherever he is, gets the same treatment throughout the country. So it is not the case in India. And of course, by the time we finish this talk, 90 people would have died of cardiovascular disease in India. Of course, 120 people would have gone. So this is the scenario in cardiovascular disease in India. So this is because many of you must have seen this slide. What is this place? Yes? Saravanabavan. So if you go to any restaurant in Chennai, you cannot enter and sit without waiting for half an hour to 45 minutes outside. So all restaurants are full. And our women folks forget to cook at home. So refuses to cook at home. So the main fast food. I call the fast food as fast food because it ends life fast. So that's why it is called fast food. So we have fast, and we forget an area called staircases. In every building there is an area called staircases. We almost forget there is a staircases are there. Even for the first floor, climbing down from the first floor, we use lifts. So you see that hardly a fellow is going through the staircases. Everybody is climbing through the escalators and lifts. This is happening in American Diabetes Association meeting. After discussing 3 or 4 hours of diet and exercise inside, nobody is willing to climb up the stairs and do some exercise. So this is the happening. So bad food, lack of exercise, and the third important factor is mental stress, the enormous mental stress. Now the mental stress starts when the student undergoes the 10th standard. When he enters the 10th standard, the mental stress starts, the student, the family, and the relatives also. Even the uncles and aunties become silent because the fellow is going for 10th standard. In 2 years, he is going to enter the 12th standard and so on. The stress starts right from there. So these are the three reasons why in India the coronary heart disease is increasing. The abnormal food habits, lack of exercise, enormous increase in mental stress. So as I told you yesterday, the main application of ECG is in coronary heart disease. I told you how it helps in the diagnosis and its management. So ECG tells you when the patient comes to chest pain, what is it? Whether it's cardiac, non-cardiac, coronary, non-coronary, acute, chronic, what it is. And what to do. Whether to plan a thrombolysis therapy, primary PCI, give a heparin and aspirin and so on. Even before you give a therapy, ECG tells you whether the therapy will work or not. Prognostication. Even at the first ECG, you can prognosticate and see whether the reperfusion will work, whether the PCI will work and so on. After giving the therapy, ECG alone tells you whether the therapy has worked. After PTCA or thrombolysis, ECG settling down, you know that the therapy has worked. As I told you, for many years of patient's life, the ECG alone tells you whether disease is progressing or regressing. So, no other investigation to do that when the patient comes to acute chest pain. So, you must also understand what is the difference between a coronary angiogram and an ECG. See, many things we always think, any patient with chest pain, immediate coronary angiogram. Even before doing an ECG, you want to do a coronary angiogram. So, the coronary angiogram tells you that your big arteries are normal. Your epicardial arteries are normal. So, that's what the coronary angiogram tells you. Whereas, the ECG tells you ultimate myocardial perfusion. The ECG tells you whether your myocardial cells are getting blood supply or not. The disease may be in the big arteries, disease may be in the smaller arteries. The disease may be in the physiological endothelial dysfunction, whatever it is. But ECG tells you ultimately your heart is getting blood supply or not. That's why the patient can have a positive treadmill test, patient can have an angina, patient can have a myocardial infarction with a normal coronary angiogram. Whereas the patient can have a normal ECG in spite of triple vessel disease. The patient may have a triple vessel disease, but your ECG is normal. Why the ECG is normal? The triple vessel disease is not affecting the myocardial perfusion. So that's why the ECG is an investigation to tell you ultimately whether the myocardium is perfused or not, whether at rest or on exercise, whatever it is. So that is the difference between the ECG and coronary angiogram. Although we believe the coronary angiogram is the biggest test, but ultimately the ECG is the main test to tell you what's happening to the myocardial perfusion, irrespective of the size of the vessels, irrespective of the function of the vessels. It will tell you myocardium is perfused or not. So there are three ECG signs of coronary heart disease, which is ischemia, injury and infarction. So there are three ECG signs of coronary heart disease, which is shown the three segments of the ECG complex: T wave, ST segment and QRS complex. So we have the major two vessels, right coronary artery and the left coronary artery. Left artery divides into left circumflex, which supplies the majority of your lateral wall. So you see that left circumflex. That's why I told you what are the leads we see for left circumflex. All the lateral wall. High lateral wall in L1 AVL, V5, V6, because circumflex supplies the lateral wall. Whereas the septum and the antral wall is supplied by the main artery, which is left antedescending artery. And of course your right ventricle and infraposterior portion, depending upon the origin of posterior descending artery, the right coronary supplies majority of times the infraposterior wall and the right ventricle. So although we have two major coronary arteries, it behaves like a three vessel system, just like our conduction system. It behaves as a three vessel system. Then recapitulate what are the groups of leads and their coronary artery perfusion. V1 is proximal RCA, V2, V3, V4 is septum and antral wall, V5, V6, L1 and anterior, L1 and AVL is circumflex, L2, L3, AVF is right coronary artery territory. So first we have to see the group of leads. So yesterday I told you how to read the ECG: L1 AVL, L2, L3 AVF, look at AVR, then V1, look at V2, V3, V4, then look at V5, V6. Because in this way, when you look at the group of leads, you will not only look at the various surfaces, but you also look at the different coronary artery perfusion territories. So first thing is to localize which coronary artery is diseased by looking at in which group of leads I have these three changes, whether ischemic changes or injury changes or infarct changes. But which group of leads we have the changes. So this is a summary: the RCA, LAD, circumflex and the RCA here, and the AVR, although we have put none, but recently we know that the AVR is a very important lead to diagnose the location of coronary artery. Also you diagnose a left hand descending artery, AVR will tell you the left hand descending artery is proximal or distal. So to localize the artery, now the AVR is very important. So we have three changes: ischemia, injury and infarction. ischemia is most often a moderate obstruction, 70-80% obstruction. Most often, not always, most often a chronic manifestation. Ischemia, the T wave change is most often a chronic manifestation. Whereas, I told you about injury. Injury is always acute. The injury is due to either acute critical obstruction or acute total obstruction. Acute critical obstruction means 90% is 99% is blocked. Still 1 or 2% of lumen is intact and the distal myocardium is perfused by this small intact lumen, not totally blocked. So that's why I call them as acute critical occlusion or acute total occlusion. And of course, when you have an infarction, it is most often due to a chronic total obstruction, which results in the necrosis of the myocardium, which is always chronic. So infarction is always chronic, injury is always acute, ischemia can be acute or chronic, depending upon what type of ischemia you have. So this is in nutshell. So as I told you here, the ischemia produces the T wave change, injury produces the ST segment change, and infarction produces the QRS change. It is going to affect the QRS and going to produce a pathological Q wave, loss of R wave in infarction. Whereas ST segment elevation or depression is a manifestation of acute coronary syndrome. So this is injury. Whenever the tall T wave and inverted T wave is a manifestation of ischemia. So this is injury, ischemia and infarction, depending upon which segment of your ECG is affected. So to recapitulate our T wave direction and the QR, you are all experts now. So depolarization happens from endocardium to epicardium. Repolarization happens from the epicardium to endocardium. So whenever you have upright QRS, you have an upright T wave. So now first we look at the manifestation of ischemia. Ischemia, which segment you are going to look at? T wave. So look at T wave. So what is the numbers for T wave? What is the number for T wave? 40% and 27. Whenever it is more than 40% of the preceding R, it is tall T wave. Whenever it's less than 20%, it is the low voltage T wave. So as I told you, it is usually due to moderate obstruction. When the T wave change is there, you can also diagnose whether the ischemia is in the subendocardial region or in the subepicardial region. As you know, subendocardial region is closer to the cavity, subepicardial region is closer to the cavity. So not only you diagnose ischemia, you not only diagnose which of the coronary artery has got ischemia, you can also diagnose in which portion of your heart muscle this ischemia is happening by looking at the direction and the contour of the T wave. Most often it is chronic. Most often the T wave change is chronic, it is acute. So so whenever the T wave gets inverted, now we look at the T wave gets inverted. Whenever the T wave gets inverted, we imagine that the depolarization and repolarization are happening in the same direction. There is a repolarization abnormality. Once you have a repolarization abnormality like the T wave inversion, the next step is to diagnose whether this repolarization abnormality is a primary repolarization abnormality or secondary repolarization abnormality due to an abnormal QRS or abnormal depolarization process. So that is the second thing you have to decide. So once you have that, you must say whether it is a secondary STT change or a primary STT change. So whenever there is a secondary STT change, secondary to a depolarization delay due to ventricular hypertrophy or a bundle branch block, you will have a abnormal QRS. The QRS will be either tall or wide. So this abnormal QRS will be followed by an asymmetrical T wave inversion, by which I mean you will have a downsloping of the ST segment and an asymmetrical T wave inversion where the descending limb will not be equal to the ascending limb of the T wave. So you will not hear where is the ST segment, where is the T wave. So everything, the secondary ST change, everything will descend as a single piece and ascend as a terminal portion of the T wave. Whereas in a primary T wave change, you can see the QRS is normal. It is not wide, it is not tall. QRS is normal. You will have a well-formed ST segment. You can see that ST segment is well-formed. Then you have a symmetrical T wave inversion. Symmetrical T wave inversion means your descending limb will be equal to the ascending limb. So whenever you have normal QRS, well-formed ST segment and symmetrical T wave inversion, you think this repolarization abnormality is primary and it is due to ischemia. Whenever you have a tall T wave or a tall QRS or a wide QRS associated with a downsloping ST segment with an asymmetrical T wave inversion, you think this T wave inversion is secondary to a depolarization abnormality. So this is what so you can see that well-formed ST segment with a symmetrical T wave inversion. Here it is here actually here you can exactly see where my ST is ending and the T wave is beginning. But here you cannot say that. The everything is a single piece, that descending limb of the ST segment and T wave are single piece and go to the peak of the T wave. Whereas here you can see that I can see where exactly my ST is ending and the T wave is beginning. So that is the important thing to understand, the difference between the primary T wave change and the secondary T wave change. So as you can see it here, this ECG I have seen many times now. So tall T waves here, tall QRS here, R plus S here more than 35 millimeters. You see the T wave there? It is downsloping and asymmetrical. So now you not only diagnose a left ventricular hypertrophy, but you diagnose a pressure overload because the STT changes are there, and look for conditions like hypertension and aortic stenosis in this ECG. Whereas whenever the QRS is wide, here the QRS is wide, the left bundle branch block. So you can see that here you can see that there is a asymmetrical T wave inversion here. The downsloping ST with the asymmetrical T wave inversion. The QRS is wide. Then you know this T wave inversion does not represent ischemia, and it is secondary to a depolarization abnormality. Whereas when you have a T wave change like this, you have a normal QRS here. The QRS is not tall and QRS is not wide. QRS is normal. You see that well-formed ST segment there. And there is a symmetrical T wave inversion where your descending limb is equal to the ascending limb. So whenever you have this type of T wave inversion, you know this T wave inversion represents ischemia, and it is not secondary to a depolarization abnormality. So register your mind this type of T wave inversion, symmetrical, deep with a well-formed ST segment, whereas here asymmetrical, downsloping, asymmetrical T wave inversion. So this is the first differentiation whenever you have a T wave inversion, whether it's a secondary repolarization abnormality or a primary repolarization abnormality. So that is the first point to decide whether it is primary or secondary. So whenever you have a T wave inversion, it indicates a subepicardial ischemia. Whenever you have a T wave inversion, it indicates the ischemia, not only ischemia, but the ischemia is happening in the subepicardial region. So as you can see, whenever the ischemia happens closer to the pericardium in the subepicardial region, that T wave has to be inverted, and this T wave inversion will satisfy all the criteria of a primary T wave inversion of well-formed ST segment and symmetrical T wave inversion. So this is a subepicardial ischemia. Most often this subepicardial ischemia, most often, not always, most often the subepicardial ischemia is a chronic one. Many times chronically there is a decreased blood supply, moderate obstruction. So you'll have a symmetrical T wave inversion with a normal QRS and so on. So you can see this in this ECG again. We can see that such a deep symmetrical T wave inversion with a well-formed ST segment. You can see that there with a well-formed ST segment. The QRS is normal. You can see that QRS is not wide or tall. So there is no depolarization abnormality here. So now we know that this repolarization abnormality is primary due to ischemia. You can see the inferior leads also. So not only now what ischemia this is. What ischemia is this? Where the ischemia is subepicardial ischemia. So not only, so now you have diagnosed ischemia, then you have diagnosed subepicardial ischemia. Then localize the coronary artery. Which coronary artery is involved here? So not only see the change, see in which group of leads you have these changes. What are the leads you have now? I have it in V3 and V4. Which artery? I have in V5, V6, L1, AVL. Which artery? I have in inferior leads. Which artery? So what vessel disease this is? Triple vessel disease. Right? Because you have the ischemic change in all the groups. So not only for first diagnose what it is, second diagnose localize in the myocardium, then localize in the coronary artery. So you keep on looking. Whenever you see the ECG, you have to do all the three things. Whether it is ischemia, injury, infarction, whether it is in the which area, subepicardial region or subendocardial region, then which group of leads these changes are happening. So which vessel is likely to be obstructed. So that's what. So it indicates that in here we have ECG changes in all the segments, all the perfusion territories. So without doing angiogram, we know that the patient may have significant triple vessel disease here. That's why many times the coronary ECG may serve as a poor man's coronary angiogram. The fellow cannot afford a coronary angiogram, but you are smart, you can do the coronary angiogram through the ECG itself by looking at the changes which are happening and predicting what coronary artery disease he has got. Primary T wave change or secondary T wave change? This one. Primary, you can see nicely there the well-formed ST segment, symmetrical T wave inversion. Which artery? Then immediately which artery? LAD. So V1 to V4, it is a LAD tertiary ischemia. No, this disease involved is in LAD. So what ischemia? Let us say what ischemia here. The important concept to understand, not all T wave inversion are ischemia. Ischemia produces T wave inversion, but not all T wave inversion. There are 108 causes of T wave inversion, but the common cause may be ischemia. Many times, young ladies just married, living with mother-in-law, coming to the atypical chest pain, will have this type of small T wave inversion. Don't brand them as ischemia. Right? These are all non-specific STT changes, most commonly happen with young ladies with a mitral valve prolapse with a minor T wave inversion. So remember, the ischemia is a deep T wave inversion. See, this ischemic T is usually a deep, very deep symmetrical T wave inversion. In a 60-year-old fellow diabetic smoker, this type of T wave inversion, you know it's coronary heart disease. Whereas here, the 22-year-old female with all sorts of atypical chest pains coming to you with a minor T wave inversion. So it says it's a subepicardial ischemia, LAD tertiary ischemia, and start the patients on all sorts of drugs and so on. So always, that's why I told you, the same T wave inversion will have a different diagnosis depending upon the patients, depending upon the possibility of coronary heart disease. That's why the ECG is different from all the other investigation. The same T wave inversion. You don't diagnose ischemia here, but you diagnose ischemia in 60-year-old fellow. So that's what the correlation of clinical findings. So the ECG interpretation. Right. Now we are going to look at an ischemia which is happening in the subendocardial region. So subepicardial ischemia produces a T wave inversion. We have diagnosed that, and we know what is the differential diagnosis for the T wave inversion. It is a secondary T wave change. Now we are going to have a diagnosis of a subendocardial ischemia. In subendocardial ischemia, you will have a tall T wave. Tall T wave is 40%, more than 40% of the preceding R wave. You will have a tall T wave. So what is the differential diagnosis for tall T wave? Hyperkalemia. Good, very good. So whenever you have a tall T wave, when the patient is coming to you with a chest pain or the renal failure, it can be hyperkalemia. With the chest pain, it can be ischemia. I will tell you the difference between both of them. So here the patient is coming with acute chest pain. So this is an exception. When the patient comes to acute chest pain, many times he will have either ST depression or elevation, but sometimes you will have only tall T waves. Acute chest pain, very tall T wave. Some acute ischemic syndromes start with the tall T waves rather than the ST segment changes. So that is the only exception. So here the clinical correlation is important. Patient has got a tall T wave, but acute severe classical retrosternal coronary chest pain, you know it is an acute coronary syndrome. So subendocardial ischemia, sometimes producing a tall T wave, could be an ischemic in origin, and it could be an acute episode which may intervene, which may require admission and appropriate treatment. So I also told you about the difference between the tall T wave between ischemia and the hyperkalemia. Ischemia will have broad base and blunt apex, whereas the hyperkalemia will have narrow base and sharp apex. You can see that arrowhead. When you look this type of T, you definitely know it is hyperkalemia. Just look immediately for, most often it is hypertension with a renal failure and so on. Many times we see in patients with hypertension, first you take the ECG, and the ECG is like this, you know, it is a renal failure which is causing the hypertension. Immediately you know it's a hyperkalemia which is producing this type of change. So narrow base with a sharp apex is hyperkalemia. So you have two differential diagnoses for T wave inversion. Two differential diagnoses for tall T wave. Whenever there is a T wave inversion, make sure it is primary. Whenever there is a tall T wave, make sure it is not hyperkalemia before you diagnose coronary heart disease. So that finishes the T wave, tall T waves, isn't it? Tall T wave is subendocardial ischemia. So not only diagnose ischemia, localize whether it is subendocardium or subepicardium, also localize which coronary artery it is happening by looking at the group of leads. So all the three steps you have to follow in each one of your ECG interpretation. So injury, what you are going to do? Look at the ST segment. ST segment is what segment? Widow making segment. So ST segment is a widow making segment if you are not careful. So majority of our acute coronary syndromes happen because of the rupture of the vulnerable block and the rupture of the vulnerable plaque produces an acute thrombus formation. This is the acute thrombus formation. If it is going to critically occlude a coronary artery and leaving a small lumen intact, the patient will land up with an acute unstable angina or a non-ST elevation MI. Whereas this thrombus is going to totally block a coronary artery and does not allow any blood flow distally, the patient will land up with a ST elevation MI. So acute coronary syndromes are diagnosed or formed because of the rupture of the plaque producing acute thrombus formation. And the quantity and the quality of the thrombus decide whether it is an unstable angina or ST elevation MI. If it is a total obstruction, it is ST elevation MI. If it is an acute critical obstruction, it is acute unstable angina. It is not only the quantity but also the quality. So CAD, we have the injury, if it is an acute coronary segment, it's a crucial segment, acute episode, either due to critical obstruction or a total obstruction, it's a widow making segment. So now I introduce the concept of the two types of injury. So whenever the patient has got a critical occlusion, as I told you the initial portion of the movie, when the thrombus has formed, critically occluding, small lumen is intact still some amount of blood flow is flowing, the patient will land up with an acute unstable angina. This acute unstable angina, when there is a critical occlusion, still there is some flow is flowing, this acute stable angina, the patient will have the ST segment depression here, which is subendocardial injury. The ST segment depression is subendocardial. The injury is in the subendocardial region, subendocardial injury. So here, not only the thrombus is critically occluding, still some amount of lumen is intact, the quality of thrombus itself is different. The thrombus here is rich in platelets rather than fibrin. That's why it is called white thrombus. So when the patient has got an acute critical occlusion due to acutely formed thrombus, which is having an acute unstable angina, manifesting as subendocardial injury and ST segment depression, you will have a critical occlusion and white thrombus. Whereas when the patient has got suddenly have a total occlusion, no flow is going distally, suddenly 100% of the coronary artery is blocked by the acutely formed thrombus. The thrombus is most often red thrombus, which is rich in fibrin, and this total occlusion will produce a subepicardial injury or a pan injury, which will come as an ST segment elevation. So although patient comes to you with acute chest pain, the ECG alone decides whether it is a critical occlusion or a total occlusion, whether it is a white thrombus or a red thrombus. That's why when the patient comes to you with acute unstable angina, severe acute chest pain with ST segment depression, you do not give a thrombolytic therapy here. You do not give a thrombolytic therapy here. When the patient comes to acute chest pain and there is an ST segment depression, you know it is a critical occlusion, the thrombus is white thrombus, so give heparin, dual antiplatelets and high dose statins and so on. So do not thrombolyze these patients who have ST segment depression. Why? Because the thrombus is not rich in fibrin. So there is no point in giving a fibrinolytic therapy. Whereas here when the patient comes to acute chest pain and is having an ST segment elevation, then you know it is a total occlusion, the distal myocardium is dying, you have to open up the artery immediately through either a thrombolytic therapy. Why thrombolytic therapy or fibrinolytic therapy here? The thrombus is fibrin rich. It's a red thrombus, fibrin rich. So you give a thrombolytic therapy here to open up an artery. So although the patient comes to you with a classical severe chest pain, both situations patient will have a classical severe retrosternal chest pain. The ECG alone decides whether to give a thrombolytic therapy or not to give a thrombolytic therapy, depending upon whether you have a subendocardial injury or a subepicardial injury. Is that clear? So a very important concept to understand in coronary heart disease, especially acute management of coronary heart disease. So as you can see that whenever the patient has got a subendocardial injury, the injury in the subendocardium, there will be ST segment depression. The ST segment depression is a manifestation of acute unstable angina. It is a viable myocardium supplied by a critically narrowed artery. So this is the initial portion of the movie. The thrombus has formed, but still a small lumen is going. Small lumen, the blood flow is going. So this is, in this situation, patient will have ST segment depression. So most often it's a white thrombus. So do not give a thrombolytic therapy at this point, because when you give a thrombolytic therapy here, that thrombus will bleed inside and produce a total occlusion. So we will convert ST depression situation into a ST elevation situation. Mostly needs heparin, antiplatelets, etc. Thrombolysis is not useful, may be harmful. here at this situation. So although the patient comes to acute chest pain, you do not thrombolyze all the patients. From the ECG, you decide whether it is subendocardial injury or subepicardial injury and so on. So only for subepicardial injury, ST segment elevation, you must thrombolyze the patient, not for subendocardial injury or unstable angina. So normally, first we understand what the subendocardial injury is. Normally, the ST segment gently merges with the T wave. It's very gentle. So you will not know where the ST is ending and the T wave is beginning, because everything is fused very gently with a slight concavity upwards. You can see that concavity there. This concavity is upwards. So this is a normal ST segment merger with a T wave. Whereas the earliest sign of subendocardial injury, I told you the subendocardial injury can produce ST segment depression. But earliest sign of subendocardial injury is the flattening of ST segment. ST segment need not get depressed, but what's happening is the ST segment becomes horizontal and you have a sharp ST-T junction. Normally the ST junction is so smooth, whereas ST becomes flat and hugs the baseline more than 3 small squares. Although it is not depressed, you know this is the earliest manifestation of CAD. The patient coming to a classical angina, when you have this horizontality of ST segment, you know the patient has got definite coronary heart disease in the form of earliest sign of subendocardial injury. We can say this is a normal ST segment which gently merges with the T wave, whereas you can see it here, horizontal ST segment with a sharp ST segment. So this is, if this ST segment hugs the baseline more than 3 small squares, you know, at a very sharp ST-T junction, this is the earliest sign of subendocardial injury, earliest sign. So this is a normal ST segment. You can see that here, how gently your T wave merges with the ST segment and see that gentle concavity upwards. So this is your normal merger of ST segment to the T wave. Whereas you can see it here, V5, V6. What is the difference? Can you see that V5, V6? You see that ST segment there? You see the ST segment is flat. You see the sharp ST-T junction there. So the ECG looks apparently normal. The ECG looks apparently normal. But this is the earliest sign of coronary heart disease. The flat or horizontal ST segment is the earliest sign, especially in diabetics. You must watch for this sign. The patient may not have any classical chest pain or angina. When a diabetic patient comes with this sign, if you do a treadmill test, it's going to be definitely positive. Definitely positive. So this is the earliest sign of subendocardial injury. Of course, when the patient goes for a classical acute chest pain, the patient will have a classical severe ST segment depression. So this is a subendocardial injury. So subendocardial injury produces ST segment depression. The important thing is it is a clinical manifestation is unstable angina. The thrombus is critically occluding. The thrombus is platelet rich, white thrombus. So the management is heparin and aspirin and not thrombolysis therapy. Is that clear? Right. So there are varieties of ST segment depression, the plain ST segment depression, sagging ST segment depression, whereas the downsloping ST segment depression associated with the abnormal QRS is most often secondary ST segment due to secondary ST change. So primary ST changes will be horizontal or sagging. So here you can see that the patient is coming to acute chest pain. What treatment you will not give? In this ECG, what treatment you will not give? Yes, that's what. So remember Hippocrates' oath, at least do no harm. Whether you are doing good or not, at least do no harm. So in this patient, you are not supposed to give a thrombolytic therapy because it is a subendocardial injury. What injury this is? What injury this is? Subendocardial injury. Subendocardial injury produces ST segment depression. The earliest sign is horizontality. So you can see after deciding subendocardial injury, what will you do next? Localize the coronary artery. So please remember whether it is ischemia, injury, infarction first, subendocardium or subepicardium second, then what is the group of leads in which these changes are seen to decide about which coronary artery disease we are dealing with. Which coronary artery? RCA, because inferior leads are there. It also has some amount of LAD and also circumflex. This once again a triple vessel disease having ST manifestation in all the 3 territories. So it's a subendocardial injury, very severe disease. Severe disease in the ECG itself tells you it's a very severe disease. The patient may have a significant manifestation or complications during the acute phase. So that is the subendocardial injury. Now we are going to deal about the subepicardial injury. Subepicardial injury is most often due to acute total occlusion, and this total occlusion is going to be by a thrombus which is fibrin rich. Here there are 2 things. The artery is totally occluded. That means your myocardium is dying. Every minute you are losing, the myocardium is dying. So first priority here is open up an artery as soon as possible. Revascularization as soon as possible is the first priority in epicardial injury. Epicardial injury produces ST segment elevation. In ST segment, so that's why ST segment elevation MI, we call them as ST segment elevation MI, is a manifestation of subepicardial injury. So sudden occlusion of a major epicardial coronary artery. So majority of our acute myocardial infarctions, what we call clinical syndrome of acute myocardial infarction, start with ST segment elevation. Mostly needs a thrombolysis or primary PTCA. Primary PTCA is the best mode of treatment in if it is available and patient can afford, that is the best mode of treatment. But in our situation, we must thrombolyze the patient as soon as possible if there are no contraindications. Of course, you can see that here the subendocardial injury has produced a significant ST segment elevation. So this is an acute total occlusion. Three things once again: subepicardial injury, ST elevation MI, total occlusion, and the thrombus is fibrin rich. So the treatment is thrombolytic therapy. So that is the concept you have to understand. So the patient comes to acute chest pain here. What's happening? What injury? Subepicardial injury. So which group of leads? Which is the inferior and V1. What artery is affected here? V2, V3, V4. What artery is affected here? LAD. So this is acute total occlusion of RCA, and what treatment you will give? Thrombolysis. Immediately thrombolysis is the treatment of choice here, because you know it is acute total occlusion, red thrombus. So these are the differences between the subepicardial injury or subendocardial injury. Both are acute events. Please remember, both are acute events. It's not as if you give more importance to ST elevation situation and less importance to ST segment depression. Both are acute events. Both should be managed aggressively. Here is an ST elevation. Here it is an ST depression. Here it is a ST elevation MI clinical syndrome. Here it is a clinical syndrome is acute unstable angina. Acute total occlusion here. Acute critical occlusion here. Fibrin rich red thrombus here. Platelet rich white thrombus here. That's why you give a thrombolytic therapy here, and you give heparin, antiplatelets and statin here, because the thrombus is not fibrin rich. So this is the concept in injury you have to understand. We can be very clear. So as soon as the patient comes to acute chest pain, you take an ECG, and the ECG decides what to be given immediately: revascularization or the heparin and aspirin. So any acute chest pain, you must first give the patient reassurance. So you must not many times when the patient enters in the hospital, no longer he is considered as a human being. He becomes a case. That case, this case, that one. No longer people answer. So you must always give a reassurance, act fast, ECG to be taken within 5 minutes to decide whether it's a ST elevation situation or a non-ST elevation situation. Sedation, the morphine is the best. If you are not treating, you must transfer as soon as possible. Instruction to go immediately and alert the. So all the three things should be done. When they have an acute situation like this, you give an appropriate drugs and send to an institution where the primary treatment may be given. So that finishes the injury. Injury is ST segment, subendocardial injury and subepicardial injury. Now the infarction. Infarction, look at the QRS. So if you are smart physician, after attending this workshop, what is your aim is not to see an infarction in your patients. You should not see the infarction. Why infarction? You should not say infarction is a irreversible process. Infarction is a myocardium is dead, necrosed and scarred. After that, whatever you do, you cannot get back normal myocardium. So by treating your ischemias and injuries energetically, you must see to that you will never see an infarction change in your patient's ECG. That is your aim in that management of coronary heart disease. You will not allow the patient to go in for a permanent necrosis, because you have to identify the ischemia early. You have to energetically treat injury early, so that you do not allow the patient to go for infarction. So if at all one change I don't like to say is infarction. So the Q wave usually represents necrotic myocardium, which is incapable of producing any electrical activation or depolarization. Is there any Q wave normally? Yes. Which leads? V5, V6. So remember yesterday we told you at least 10 times the first septal activation is going from left to right by the intact left bundle, producing a small initial Q wave in V5, V6. So that means you have to differentiate what is physiological and what is pathological, right? So not all Q waves represent myocardial infarction. So you can have physiological Q wave in V5, V6 because of the septal activation going from left to right by the intact bundle. So you may have a small initial Q wave in V5, V6. So whenever the Q wave is broad and deep, it is considered pathological. Broad and deep Q wave. There are three criteria to diagnose a pathological Q wave. One, the Q wave should be more than 1 millimeter in depth, and it should be more than 0.04 second in duration. So it should be broader than 1 small square. It should be, physiological Q wave is usually 1 small square and less, whereas a pathological Q wave is broad and deep. And third criteria to diagnose a pathological Q wave is it should be more than 25% of the succeeding R wave. For example, it is a QR. If you estimate the QR as amplitude versus the Q wave depth, the Q wave depth must be more than 25% of the R wave amplitude. So three criteria: more than 1 millimeter in depth, more than 0.04 second in duration, and of course the 25% of the succeeding R wave are the three criteria to diagnose the Q wave. So you can see that here this is a physiological Q wave. You can see that very small tiny Q waves there, V5, V6. So you know when this type of Q wave is there, you know it is a physiological. It is not deep, it is not broad, and it is a septal activation going from left to right, resulting in a small initial R wave in V1 that is corresponding initial Q wave in V5 and V6. Whereas look at here the inferior leads. You see that Q wave there. The Q wave is so deep, so broad, and it is more than the R wave. So then you know this Q wave is pathological Q wave, and it represents what? I don't want you to say old infarction. All these terms should not be there. This Q wave represents necrosis, right? What artery? RCA. RCA, what occlusion? Acute occlusion, chronic occlusion, or moderate occlusion? Chronic occlusion. Chronic total occlusion or chronic total occlusion of what? RCA. So when I show ECG, what you must say in a single sentence? Chronic total occlusion of RCA. When I have an ST elevation in inferior leads, let us say, imagine this inferior leads have got ST elevation. What is the single sentence diagnosis? Acute total occlusion of RCA. Let us say inferior leads have got ST segment depression. What is your single sentence diagnosis? Acute critical occlusion of RCA. So try to interpret ECG in this way, because it will give you an idea of pathology. It will give you an idea what to do for that particular situation you are dealing, rather than saying old myocardial infarction, recent myocardial infarction, like that. So if you start imagining the main pathology and the coronary artery, you will be much better off in your management. So this is a chronic total occlusion of RCA resulting in a pathological Q wave in inferior leads. So now we must understand how this pathological Q wave is produced electrophysiologically. So I told you, when you have a myocardial necrosis, it's not as if that necrosing myocardium is producing a Q wave. The necrosed myocardium is incapable of producing anything. It will not produce any wave. So it has been postulated that this necrotic myocardium acts like an electrical window for the lead which is facing and showing the distant away going depolarizations, which results in a Q wave. For example, in a normal depolarization, what has happened? Let us imagine my lead is here. My septal activation is going away. Then there is a simultaneous activation of right and left ventricle. My left ventricular activation would have produced the tall R wave in V5, V6, isn't it? That's what would have normally happened. Here now this myocardium is dead now. So this activation front, the main dominant vector, is not there. So what this lead will see, the two vectors which are going away, the septal vector is going away from it, and the right ventricular depolarization is going away from it. So this lead will look at two depolarizations going away, which is shown as the Q wave, and not the myocardium is producing a Q wave. So the myocardial infarct area acting like electrical window for the lead facing it and showing the distant away going depolarization, which is shown as the pathological Q wave. So this is the genesis how the pathological Q wave is produced, rather than the myocardium itself is start producing a Q wave. So this is what happening. So this is a pathological Q wave, which is broad and deep. The Q wave in myocardial infarction is amplitude is more than 28%, duration is more, and the depth is more. So that is the definition of pathological Q wave. So that's why the next thing is to decide whether below a particular lead, whether you have a total myocardial necrosis or some amount of healthy myocardium is there, whether the myocardial area is more or the necrosed myocardium is more. Having decided there is necrosis. Below that particular lead, there may be total necrosis, there may be small myocardium which is healthy, or total myocardial infarct area may be little. So you can see this ECG, you can see that V1 to V3, V1 to V3, there is no R wave at all, isn't it? Normally what will happen, V1 to V3, the R wave should progress from V2 to V3, the R wave should keep on increasing. So here absolutely there is no wave. So it's a pathological Q wave. In what territory now? What territory? LAD. So depending upon the depth of the Q wave and the succeeding R, you can decide whether below that particular electrode I have a total necrosis or healthy myocardium is more or infarct myocardium is more. For example, let us see here. Here my infarct myocardium is more and I have a small healthy myocardium. So below this lead, I will have a Q wave which is deeper than the R wave. Because my healthy myocardium is small, my R wave is small, my infarct area is big, my Q wave is big. Whereas here, I have a small area of infarct, but my healthy myocardium is more. So here, although I have a pathological Q wave, the Q wave depth is less than the R wave amplitude. So whenever the R wave is tall and the Q wave is small, then you know below that electrode, I have small infarct area and a predominant healthy myocardium. So Q wave is deep, more of infarct area, less of healthy myocardium. When the Q wave is small, more of healthy myocardium and less of infarct area. Whereas there is no healthy myocardium at all. From the epicardium to endocardium, the whole thing is infarcted. I will not have any R wave at all. Below that electrode, I will have only Q wave, only the Q wave without any R wave. So look at this ECG here. V1 to V3, V1 to V2, V2, I don't have any R wave, isn't it? So what I imagine, below V2, I have totally dead myocardium. Whereas V3, I have a deep Q and a small R. So below V3, what I have? More of infarct area, less of healthy myocardium. Whereas see V4, my R wave is big and the Q wave has become smaller. So below V4, I have more of healthy myocardium, less of infarct myocardium. So total QS, deep Q wave, small R wave, small Q wave, big R wave. So not only diagnose myocardial infarction, below that particular electrode, you know, whatever. So for example, let us say V1 to V6, I have no R wave at all, only the Q wave. Let us imagine one ECG is showing V1 to V6, only the Q wave. What does it mean? Throughout our myocardium, I do not have a healthy myocardium, so this patient has got a significant LV dysfunction. The whole of the left ventricular myocardium is dead, no healthy myocardium. Whereas infarct like this, what I infer? Only a small area I have infarct, majority of area is still healthy. So this fellow will have a good prognosis. Whereas a fellow who has got V1 to V6 with no R wave, V1 to V6, everything is Q wave, this fellow will have a bad prognosis. So not only diagnose infarction, you diagnose how much of the myocardium is involved in this infarction process. The last thing before we adjourn for tea is a posterior myocardial infarction. So it's easy to diagnose all myocardial infarctions, isn't it? But I told you the posterior myocardial infarction can be diagnosed only by the reciprocal changes we are happening in the anterowall infarction. So when the posterior wall infarction is there, if we are able to record an ECG placing an electrode on the posterior surface, what will it show? It will show a pathological Q wave, isn't it? It will show a pathological Q wave and inverted T wave because of the ischemia. So I am not doing that. So what I am trying to do is from V1 and V2, I am trying to interpret what is happening in the posterior wall. So when the posterior wall, this is exactly the opposite things is going to happen in my anterowall. So the Q wave will become the R wave, inverted T wave will become the upright R wave. Remember, so the posterior wall is diagnosed especially in the presence of inferior wall infarction, the presence of tall R wave in V1. So in all inferior wall infarctions, you must immediately look at, everybody will be looking at the inferior leads to diagnose inferior wall infarction. You must do what? You must look what others will miss. Others will miss posterior wall infarction. You must immediately go and look at the V1. If the V1 shows a tall R wave in the presence of inferior wall infarction, what is you infer? In addition to inferior wall infarction, you have posterior wall infarction because this R wave in V1 represent the Q wave in the posterior region. Right? So that is the importance of looking beyond what is obvious. Like in this ECG, you can see what is the diagnosis here. What is a single sentence diagnosis here? Chronic occlusion of right coronary artery. So it's a chronic total occlusion of RCA because you have a pathological Q wave. You have a pathological Q wave. What I wanted to see, tall R wave. You immediately look at V1. Tall R wave with the upright T wave. So what does it mean? Posterior wall infarction. Is there any other conditions you know which can produce tall R wave in V1? Right ventricular hypertrophy, right bundle branch block. So what are the three reasons of tall R wave in V1? Right ventricular hypertrophy, right bundle branch block, and how will you differentiate between these three? Why can't be a right ventricular hypertrophy here? You tell me. Excellent. So why it's not right ventricular hypertrophy? Tall R wave in V1 more than 7 millimeters. Why not right ventricular hypertrophy? What is your axis? It is actually left axis, going towards the left, isn't it? So it cannot be a right ventricular hypertrophy. Why it is not right bundle branch block? QRS widening is not there, right? QRS widening is not there. That's why it is not right bundle branch block. It is associated with inferior wall infarction. So what is the diagnosis? Posterior wall infarction. So if a tall R wave associated with right axis deviation, right ventricular hypertrophy, tall R wave is associated with the white QRS right bundle branch block, tall R wave associated with inferior wall infarction, posterior wall infarction. These are three differential diagnoses for a tall R wave in V1. Is that clear? So it's very logical. ECG is so easy. Only thing is you have to keep on applying the logical things and put it in appropriate place. So there's a classical posterior wall infarction. Most often the T wave will be upright. Many times you have seen the T wave in V1 is down, but here the inverted T wave in posterior wall will be seen as an upright T wave in V1. So always in inferior wall infarction, look at the posterior wall. So this is the summary slide. So in coronary heart disease, we have three manifestations of ischemia, injury and infarction. Ischemia is shown by the T wave change. The ischemia can be subepicardial ischemia, which will produce a T wave inversion. Subendocardial ischemia will produce a tall T wave. For T wave inversion, the differential diagnosis is secondary STT change. For the tall T wave, the differential diagnosis is hyperkalemia. When there is an injury, it can be, you have to look at the ST segment. It can be a subepicardial injury which will produce an ST segment elevation. Subendocardial injury which will produce ST segment depression. Subepicardial injury is acute total occlusion, red thrombus, myocardium is dying, you must do a thrombolytic immediately. Whereas subendocardial injury, critical occlusion, white thrombus, viable myocardium is still present, you must give heparin and aspirin and do not thrombolyze these patients. Whereas infarction, it affects the QRS complex, produces a pathological Q wave, differentiating between the physiological and pathological Q wave, and it is irreversible. As I told you, by energetically treating ischemia and injury, you should not see infarction in your patient's ECG. And how to diagnose a posterior wall infarction? The opposite of Q wave in V1 and V2 in the presence of inferior wall infarction, and the three differential diagnoses for tall R wave in V1 completes this lecture. And of course, ischemia, it can be acute or chronic. If it is a subendocardial ischemia, tall T waves still could be an acute coronary syndrome. ST segment is always acute and infarction is always chronic. Right?